She worked as a diabetologist in Mumbai since 2002, moved to the US, completed her fellowship from KU Med Center, and has been in practice ever since. She was initially at St. Luke's Health System and is now working at federal facilities and involved with teaching with students and fellows from KU. Next to her is Dr. Minnie Abraham, also an endocrinologist, started her career as an assistant professor in the Department of Endocrinology at SIU School of Medicine, Springfield, Illinois. She served as faculty, taught future doctors, was part of their research, and contributed to numerous publications, presentations, and academic lectures. She's been in private practice in Overland Park for the last 20 years and also holds an adjunct faculty position at the Kansas City University School of Medicine. Dr. Pan, next to her, completed her medical degree in India in 2000, later moved to the US and completed residency at the University of Missouri, fellowship in endocrinology from KU Med Center, worked as an endocrinologist for KU until 2010, and since then has been working at the St. Luke's BJC Health System, currently Chief of Department of Endocrinology there, and has a lot of teaching experience with University of Kansas Medical Center, with mentoring, precepting medical students as well as residents in the inpatient and outpatient settings. She has several publications and posters. Dr. Gariraju earned her doctorate of pharmacy degree from University of Kansas in 22, completed residency training in specialty pharmacy and primary care management of diabetes and hypertension. Following residency, worked as a health outcomes pharmacist, helping patients achieve their A1C, LDL, and blood pressure goals through side effect management, adherence support, and patient-centered education. She now serves as Field Medical Director at Bridge Bio, where she focuses on advancing awareness and improving access to care for patients living with rare conditions. Dr. Mandali earned her doctorate in nutritional sciences from Oklahoma State University. She's registered dietitian in the state of Kansas and Missouri. Currently working at University of Kansas Medical Center and is the director for the Doctorate in Clinical Nutrition Program, Department of Dietetics and Nutrition at the University of Kansas Medical Center. She gives courses on dietary supplements, frontiers in nutrition therapy, advanced nutrition assessment, and has presented her work at multiple conferences. She remains committed to advancing nutrition education, clinical care, and research. Dr. Raval got her bachelor's and master's degree in physical therapy in India, got her doctorate from University of Kansas in rehab medicine, in novel projects focused on type 1 and 2 diabetes that culminated into patents that have been approved in the US, Canada, and Europe. She then joined KU Cancer Center as a postdoctorate fellow, and throughout her career has been actively engaged in research and teaching. She has numerous publications in reputed international journals and has also received awards for her teaching excellence. Her professional experience includes working with orthopedic, neurologic, and endocrine patients. She's currently an associate professor for the Doctorate of Physical Therapy students at the University of St. Mary's, Leavenworth, Kansas. So as you can see, it's quite a varied group with a lot of experience. They're all here on behalf of IAKC, and we can, I think, start with presentations with Dr. Patel. We'll take questions at the end.
My topic today is pathophysiology, how we get obesity, how does it happen, definition especially when it comes to putting into perspective of South Asian population for both diabetes and obesity. A little bit into definition, especially considering Asian population. We typically, if you put obesity, there is a certain BMI. BMI is body mass index. So what they do is they take your weight and your height into consideration, and then they come up with a calculation. So if you use a general definition for obesity, it does not work that way for Asian population for some reason. Genetic factors and how our body is built, our obesity definition is at a little lower thresholds of the BMI. So for Asian specific cutoffs, overweight is considered when your BMI is more than 23, especially because that's when we start having risks at heart disease, stroke, other circulatory disorders, and things like that. And obesity is considered when your BMI is at 27.5 and more. And both American Heart Associations and American Diabetes Association, they endorse this lower threshold specifically for the South Asian population for when it comes to screening and giving clinical care. We'll talk a little bit about adiposity and a thin fat kind of phenotype. Why we would say that? Because compared to Caucasians and other races, South Asian population, we have a lower BMI, but we still have a lot more factors that count towards a little higher adiposity, which means we could be thin when it comes to a general population, but we still would be considered obese if you define it at other clinical measurements. In the sense, the first one over here is waist to hip ratio. So what we do is when you go to your doctor, they will measure your hip, they will measure your circumference around the hip area and the waist area, and then they come up with a ratio. Now you could have a lower ratio and you still will be considered obese in South Asian population. Unfortunately, compared to other races, the total body percentage is also high, which means if you have, say, 100 kilogram body weight, a certain percentage comes from muscle, bone, fat, and things like that. Unfortunately, a South Asian population is predisposed to have a little higher body percentage. A lot of fat disposition is more in the central or in the abdominal or the belly area. And the adipocyte is nothing but a cell, a fat cell. We tend to have a little larger fat cell. And a lot of the time, what happens with obesity is inflammation. If you get inflammation from those breakdown of the cells and things, that causes more of a problem than the weight itself. Unfortunately, the inflammatory response is a little bit higher when it comes to South Asian population. And the worst part, it really starts very early in life. Next. So when I was talking about waist circumference, the cutoff for Asian men is 90 centimeters, which is about 35 to 36 inches, which is like imagine having a pant size of 36 versus it would be 40 and above for a non-South Asian population. For women, the cutoff is 80, which is about 32, about 32 pant size, something like that, when it's much more at 36 and above for a non-Asian population. Next. And the other difference we have is we have a lot of ectopic fat deposition. In the sense, our liver, our pancreas, they have a lot of fat collected in that, which also makes the response of the liver and pancreas to how our insulin functions different, making us more prone to diabetes. We have unfortunately lower lean muscle mass, which is more of the muscle where the glucose is taken up after we eat. The volume of how much of insulin we have is much lower, and we would have a lower weight and still a lot of insulin resistance, which simply means we have insulin, it just cannot function right to control the sugar. This just depicts a difference. This was a UK-based study, and it shows at much lower BMI compared to Caucasians and African Americans at different races of how diabetes starts. You can see it as low as 24 BMI, which is not even considered overweight for if you look at overweight definition. Next. So there was another study they did. What they did was they gave glucose and looked at the response of what happens with that based on how much your body insulin response would be in different population. In youths, they did this study in a younger population. In the somewhere age of 20s and 40s, And you will see that unfortunately South Asian population have a lot of fat deposited in their liver, in their pancreas, and the response to how the insulin is to the sugar was much more different. And this starts at a very, very, very young age. The other interesting thing is, like, there's a lot of talk about GLP-1. I'm not going to go into too much of details of GLP-1, but when it comes to differences of what GLP-1 does to our body, so what we see is the GLP is a molecule that helps the insulin work better. But unfortunately, the response of how the GLP should be to any sugar intake is much more blunted and different. And so we don't have adequate response for from the GLP to help in the insulin to work better when it comes to South Asian population. And that makes us, unfortunately, very prone to have diabetes at much younger age, at much lower insulin, in the sense you would have a lower weight, lower carb intake, but still have an accelerated response and a much higher glucose in response to food and early onset of diabetes.
Okay. We'll now hear from Dr. Abraham.
Is it okay if I stand up and speak?
Sure.
Yeah.
My apologies, it's taking, there's a delay in loading the slides, so that's why it's taking, should I go over?
Yeah.
I can use, but there are some slides.
Well, we can say a word. Tophi is the name they were given to us. We are thin outside, fat inside.
Right. So
So even though we are thinner,
it's called normal weight obesity. All right, so I'm Minnie Abraham, I'm an endocrinologist. So I'm going to talk about the miracle medication that you probably already heard about, right? So everyone knows about Ozempic, right? Yes. So the slide is back up. We know the obesity and diabetes, both globally, there is increased prevalence. So combining the two terminology, we are using the word diabesity because of the strong interlink between obesity and diabetes. Okay, that's a slide showing adult obesity rates in the United States. As you can see, it's self-explanatory. The darker the color, the more obesity. You can see cancers right in the middle. The next slide, please. Okay, I wanted the previous slide. Yeah, that's a slide showing child obesity rates. If you actually memorize the previous slide, you could see where the child obesity rate is the highest, where adult obesity is the highest, that directly correlates with child obesity in the same states. You can see the color difference actually. So it's a big epidemic, not just in the United States. It's a global problem, that obesity in the adults and in the children. So again, coming back to diabetes, there are more than 50 obesity-related problems emerged. And I want to emphasize this when I use the word obesity. Obesity is a kind of a derogatory terminology, but please understand, we use that term just to discuss medical conditions that could happen from weight gain. So we never use the word obese person. We always say person with obesity or people with obesity. Just like any other medical diagnosis, a person with the diabetes, a person with obesity. So we have to be respectful when we use that terminology. That makes a big impact when we talk to our own family members, our children, and when we talk to our patients actually. So the word obesity will come in all our discussions today, but it just implies health conditions that could happen in relation to weight gain. So there's a list of problems there, and these are things most of us know is diabetes. Diabetes comes with what? High cholesterol, high blood pressure, heart disease, heart failure. Then what else happens with the weight gain? Arthritis. Knee joints don't like to carry that weight. Sleep apnea, multiple cancers. So all together leading to increased morbidity and mortality. It affects quality of life. And you are living longer but with burden of many medical problems. So directly related to the weight gain. Okay, this is a fun fact. I don't know if most of you know about this little lizard. It's the Gila monster. So the fun fact is, the medication that we are talking about, the GLP-1 receptor agonist, most famous one is Ozempic. So I'm just going to use the word Ozempic because people can relate to that because everyone hears about Ozempic. So apparently this molecule was initially discovered in the saliva of Gila monster. That molecule was available long time ago. And then when we discovered that humans, we actually produce a hormone in our gut. It's the gut hormone, it's in the gut actually. So they found it very similar to this particular hormone in the saliva of Gila monster. So the Gila monster has this ability to adjust their metabolism actually, so people were very curious about how this little lizard manages its metabolism. They can eat whatever, sometimes they don't eat, but they maintain the metabolism. So when that molecule was available, we found that similarity, and actually the first medication in that family was launched more than 20 years ago. It was called Byetta. I don't know if anyone remembers that. It was the first medication, and it was a twice daily injection. Then we came a long way from that, and now we have the once a week injection and better products, better molecules available actually. So that is the connection to Gila monster. So we share a lot of things with other species, so just a little fun fact. So coming back to the medication, the family of medication that I'm going to talk about is technical terminology is GLP-1 receptor agonist. So this GLP is a hormone, like Dr. Patel mentioned earlier, it's a hormone that we produce naturally. So this medication is an agonist. It makes it more, it gives the benefit of this particular molecule in several hundred times in strength. So this is actually a very revolutionary medication. For endocrinology, it's a revolutionary medication. So I told you the first medication came out more than 20 years ago. But most people know about this medicine only in the last, few years. Because when it was approved for weight loss. So the medicine is not new. We've been prescribing this medication for over 20 years. So we know this family of medication. We are getting better and better newer molecules as time goes on. So let's look at what's the good, what's the bad, and what's the unknown about this family of medication. Like in medicine, there is nothing 100% safe. Nothing 100% guaranteed. So every medicine has good, bad, and the unknown actually. So how this medicine works. We talked about GLP-1, right? That's a little protein, it's like a hormone. It goes to these receptors. The receptor is like a docking station. So our human body produces a lot of hormones. There are many hormones. And all these hormones get docked into the receptors, and then you see the outcome. So these receptors are everywhere in the body, and that's the little picture showing brain, heart, lungs, stomach, fat tissue. So you can understand, how this particular molecule or this medication can impact the whole person. So every place it has a specific action also. One of the notable mechanisms of action is this medicine makes the food go slowly in your stomach. That's why you see the TikTok and the social media saying it causes stomach paralysis. That's how the medicine works. It makes the food go slowly in your stomach. So many good things happen. When the food goes slowly in your stomach, you don't feel hungry in between meals. And then for patients with the diabetes, when the food is absorbed slowly, you don't get the spike after meals. So many benefits because of that mechanism of action. And the other thing is it stimulates the satiety center in the brain. So with the smaller portions, you feel full. So I have a joke, I tell my patients, I prescribe this medication, but I counsel them, okay? When you feel the fullness, you have to stop eating. If you try to finish the plate, you'll feel it. So basically, this medicine is bringing back or giving you a sense of self-discipline that we should have probably developed. eat small and eat what you need, that kind of philosophy actually. So it's hard, self-discipline is hard, change is hard. So, but with the help of the medicine, it becomes more natural. So that is what, the two main mechanisms of action. Then okay, so I'm going to stop there. So every organ, it has a beneficial impact, and we have a lot of studies showing that it has a impact to reduce cardiovascular risk. So there are multiple studies. It's done by a pharmaceutical company, but at least a half a dozen studies showing that there is reduced risk for cardiovascular disease, and that's the name of the studies. There is no need to memorize that, but about 26% of risk reduction in cardiovascular disease. So that's a game changer for us. As endocrinologists, we try to manage blood sugars. We will give them many medications, including insulin, to bring down blood sugar, but we did not have a medicine to offer to reduce heart disease. What happens? Type 2 diabetic patients, most of them, the final outcome is heart disease. So this is a medicine which actually can reduce the risk of heart disease by 26%. Then it can reduce the risk of stroke. It can protect the kidney. So you're talking about all the major organs that could be impacted by the result of type 2 diabetes. So all in all, from what we know as of today, this is a great diabetes medicine. So that's a good. Then FDA approved it for weight loss. Why? Because the company was watching. So we've been prescribing these medications for 20 years. So there is data. People are losing weight. So then they looked at it together. Okay, well, this could be a weight loss medication. Because for about a decade, we didn't have any weight loss medications. So we were literally looking for something we could use. So FDA approved it for weight loss. Why? Because of the safety profile. And that's when all the social media picked up. The FDA approved this medication for weight loss because of its safety profile. We've been prescribing this medicine for almost 20 years in our high-risk patients. Those are patients with diabetes, right? They are at the high risk for heart disease. So we proved by prescribing this medication for many years that these medications are safe, not just safe, they can actually reduce heart disease. So FDA was comfortable approving this medication for weight loss, and ever since then, everyone knows about Ozempic. So that's the generic, the pharmaceutical, the name semaglutide, Wegovy for weight loss, the same molecule. So, all the social media picking up all these medications and everyone knows that. So this Wegovy is the same molecule as Ozempic. It is approved just for weight loss. You don't have to have diabetes approved for weight loss, even in children. So that approval came a long time ago, above age 14, it was approved for weight loss. Recently, another medication, Mounjaro, in the same family is approved above age 10 to treat type 2 diabetes actually. Okay, so we already talked about all the good things. It protects the heart, prevention of stroke, protects the kidney, protects the liver. So we may even get a lot of indications, including fatty liver and things like that. So the next speaker is going to touch base with that. So the bad. So those are the side effects. I'm not going in depth into the side effects because Dr. Bani is going to talk about that. The common side effect is GI symptoms, nausea, vomiting, and usually the side effects happen if you don't follow any dietary restriction. So we never prescribe this medication without counseling our patients. So they have to have some kind of common sense dietary restriction before we start the medication. And then the cost of the medication also. So it's very expensive in the United States. It's coming down, the cost is coming down, but not enough. As you know, the molecule is very old. It's not expensive, but because of so many other explanations and reasons, it's highly priced in the United States. When we were paying $1,000, it was $92 in the UK. So it's a different healthcare system, actually. And then the social media misinformation about Ozempic face, Ozempic personality, gastric paralysis, so many bad information. So my advice to all of you is listen to go to your doctor. Get your medical information from somebody who actually went to medical school. Okay, the unknown. So the unknown is how long can anybody take these medications safely? And that's a question we should ask for any prescription medications out there. So I told you we started prescribing this medicine about 20 years ago. So far it seems to be pretty good. So let's say if you are starting this medicine for type 2 diabetes. Type 2 diabetes is lifelong. So if you have a good medicine to treat type 2 diabetes, that can give the benefits of protecting your heart, your kidney, and your brain. It's good to continue that medication, and they should be on it lifelong. We are not stopping that medication when we start this family of medicine for anybody with the type 2 diabetes, no matter at what age actually. So if the medicine is being prescribed only for weight loss, what happens when you stop the medication? Any guesses? Exactly. So that is the concern, and that's the $1,000,000 question. Like, if you just take the medication, okay, you paid for it. Some people pay out of pocket because they want to see some weight loss, and they paid the money and took it for 6 months or 1 year. There was weight loss. When you stop the medication, the weight will come back actually. So that's very common with any weight loss medications. Even bariatric surgery, 25% of individuals gain the weight back actually. So there is something about that which we still do not understand. What's happening is it's in the brain. That's what we think, but we do not understand why that happens. So if you are taking the medicine for weight loss, it is almost guaranteed that the weight could come back the minute you stop the medication. So it's a commitment also. So that's what we counsel our patients, you start with the lifestyle changes. It's good to maintain the lifestyle changes, but if you're starting the medication, this is a commitment. You cannot stop after 2 years. Then you lose everything that you gained. Ironically, the other way actually. So, and it's not good for the body to lose and gain and lose and gain actually. So that is an area of concern. So this is I just want to bring this slide because the company did a study in children aged 6 to 12 years, and they proved this family of medication is safe. So when I saw that study, I didn't know how to react to that because I felt sad and disappointed because we are doing studies in 6-year-olds for a weight loss medication. And in that particular study, 2 children actually had type 2 diabetes, 6 to 12. So we are seeing type 2 diabetes in children. Pediatricians are treating type 2 diabetes now, so they don't even know how to treat type 2 diabetes because they have seen only type 1 diabetes in the pediatric age group. So we are seeing more type 2 diabetes in children in association with obesity going up in the children also actually. So from whatever studies they have done, it seems to be safe in the pediatric population also. So prevention of diabetes means obesity and diabetes education. And I cannot emphasize enough about how much education that we could provide. And I think we are failing as even I will call out my own colleagues that we are not spending enough time to educate the community or our patients. And doctors, healthcare providers, lawmakers, we are not doing enough to educate our community. So coming about obesity and type 2 diabetes, even if we have the, of course, South Asians, we have our genetic pool is not the greatest, but we can still alter the course of the disease. I tell that to my patients, well, you have the genetic predisposition, but it's your choice when you should get it. Whether you want to get type 2 diabetes when you're 25 versus 65, there is something we can do about it. And the lifestyle is very basic. And you don't have to pay much for lifestyle. Getting good sleep, eating with some common sense, being active, and stress management. And if the parents are following this, it's most likely the children will be healthy also actually. So encouraging lifestyle modification and providing education. So I would say one more thing about this family of medications. It's a great type 2 diabetes medication, but I'm still conflicted about using it just for weight loss. And as endocrinologists, we don't use the terminology even weight loss. We call it weight management, because everybody's weight is everybody's weight, and thinness or the number on the scale does not translate to health. So our focus is health and wellness. So as endocrinologists, I'm going to just take some pride about that. We are all about health and wellness, not about weight loss. So I tell my patients, weight loss that's not a goal. That's not the goal. You want to lose something? No, we want to gain something, which is health and wellness. So coming to this family of medication, yes, there's a great place for these medications in the community, patients with diabetes, and even for weight management in our seniors. Because, it will improve quality of life. So people suffering with arthritis, they cannot even make a couple of steps. But if you lose some weight, they can enjoy life better, they can move around, it might improve their wellness actually. So I see a great role and probably an indication. This is my opinion, but the medicine is very expensive, and I also heard that starting in July, CMS is going to do a bridge gap program for weight loss for seniors, $50 per month, but it's only for a year and a half. So that's the problem is this, if the government does not continue that after a year and a half, you may end up stopping the medication actually. So I am disappointed that we don't have the ability to offer this medication to those individuals who actually need the medication because of the cost and the lack of coverage. I'm also disappointed that we are approving the medication for use in pediatric population, but we are not doing enough to prevent pediatric obesity. We have a duty to our children, the next generation. We are not doing enough. Policymakers, lawmakers, parents, healthcare providers, we all should unite together to offer that to our next generation, that they should eat well and they should play outside. Thank you.
We will hear now from Dr. Khan.
Good afternoon, everyone. Thank you, Dr. Patel and Dr. Abraham, for your excellent talks. And I don't have much to do anymore. I'm just going to talk about the different types of GLP-1 and GLP combined with GIP receptor medications that are available in the market, which Dr. Abraham has already alluded to. So the first GLP-1 that was actually launched into the market was exenatide, or the trade name is Byetta, and then it had a long-acting version called Bydureon. That was 2005. So these medications are absolutely not new, but back when Byetta was introduced, it was a short-acting molecule, so it had to be given twice a day. And it was mainly used for diabetes because at that point we did not know that it would also have a weight loss potential. And it was approved for diabetes. We had it for several years, and that is the only thing that we had for a while. I will go over the benefits and the common side effects in the end for all together because most of them overlap, so it's not really necessary to go over these one by one. And then the blockbuster, actually before that, I don't know why this happened. So then after that, we got liraglutide, or the trade name is Victoza, and then it got its counterpart for weight loss called Saxenda. And the breakthrough was that liraglutide was a daily injection. Instead of having to do it twice a day, it was a daily injection. You need to talk to anyone with diabetes who has to self-inject multiple times a day, how much just one less shot means. So this was another breakthrough. It had slightly better side effect profile compared to Byetta, and the weight loss effect was about 3 to 6 pounds in general. So not that huge amount, but still better than what we had before. And what these medications helped do is for people who were on, say, pills for diabetes management, and they were on multiple different pills, but the effect was that they needed to go to now insulin. That is what these medications have helped prevent many patients to not need insulin for a longer period of time, or those who were already on insulin, they were able to back off on their insulin doses as well. To some people not needing any mealtime insulin, and others who were taking long-acting insulin were able to lower the dose or even eventually stop the medication altogether. And we'll come back to that, how it affects overall health. Then we had Trulicity, which is dulaglutide. It's a good medicine, we still use it. It's from the same makers as Mounjaro, which you probably all have heard, or Zepbound is the other medication from the same company. That has become a blockbuster in the last few years, but they still have this medication available, still works well. It's easier to do it in a way that it's all self-made. You don't have to put needles on. You can just literally remove the cap, dial it to unlock position and give yourself an injection. Then is the blockbuster that first arrived in the market in 2017. That is called semaglutide, and you all know it by the name of Ozempic, or now by the name of Wegovy for weight management. And Ozempic was actually launched for diabetes management. And from a personal experience using Ozempic, because when any new medication is launched, a lot of times the companies will reach out to physicians who prescribe or who are at higher likelihood of prescribing these medications to give them as samples to trial out. And within the first few months, we saw the effects of this medication in terms of weight loss as well as the decreased need of other oral medications or insulin. And that is where we knew that it was just a matter of time that we would have this medicine available as a weight loss medicine as well. In 2021, tirzepatide was launched, which was a dual molecule, meaning it has two components. It's a GLP and it is a GIP. It has another mechanism by which it helps control blood sugar. So these medications work at multiple levels, from the brain into the pancreas, into the liver. That's how this whole mechanism of satiety, improved outcomes from there are studies that show that it can help with high output heart failure, metabolic associated steatohepatitis, or in local terms, fatty liver, sleep apnea. Some of these medications are indicated already for sleep apnea, chronic kidney disease. So there are lots of beneficial effects that we have seen with these medications. And so far, tirzepatide is our one medication in this group that has the most weight loss effect besides helping with diabetes management. There are additional medications that are on the horizon that actually have even better potential with weight loss. And we'll come to why does weight loss become important in patients with diabetes? I told you all before that with these medications, a lot of people have been able to either decrease the oral pills that they would take, such as a group of medicines called sulfonylureas. Glipizide or glyburide might be medications that some of you may have heard. And then of course the insulins, right? None of those medications have been shown to have any cardioprotective effect, meaning heart protective effect, or weight loss. And indeed, people had to keep up. They had to eat timely so that they would not end up with low blood sugars. What's the end result? That here you're trying to control blood sugars, but you are going to gain weight as a side effect of these medications. And we did not have much in our hands to do anything about it for a long time. You would see that these people would not be happy about all the weight that they would gain over time just trying to prevent lows, but at the same time they had to also control their blood sugars. So again, with the GLP-1s, what have we seen? We have been able to discontinue or decrease the amount of these oral or injectable medications, especially insulin, and that has led to a significant improvement in quality of life. This is a huge issue. Remember, diabetes is a lifelong process. It's not going to go away if you wake up tomorrow. It's just not going to go away. So you have to live with it for the rest of your life. And how could you live with it in a manner that can give you a little more agency on your own health? And I believe that these medications have been the breakthrough for that particular aspect. And like I said, there are oral medications now in this group because a lot of times people are just leery of taking injections. They don't want to touch a needle, and a lot of times there is misinformation about this medicine being injection insulin, which they are not. They are a completely different group of medicines, but they have been available mostly as injections. However, in the last few years, we have had oral medications, Ribelsis, which is the counterpart for semaglutide in an oral form, and the same is true for Wegovy, which is available in a pill form as well now. There was a month ago a new medicine launched called orforglipron, or the brand name is Foundayo. It is a non-GLP medicine that can be given for weight management as well. So better for people who just don't want to do injections. And as I said before, there are many medications on the horizon. There are like at least 5 of them that are currently in trials that will be available hopefully in the next few years that are even going to be better. There is a molecule that has 3 different actions, GLP, GIP, and glucagon, that actually has even close to 30% of weight loss capability. Again, how does that tie into diabetes? Is the less you weigh, the less you will have inflammation, the less cardiovascular, stroke, liver, kidney dysfunction people might experience long term. Coming to side effects, because of course there is nothing in this world, even that over-the-counter Tylenol, that cannot potentially cause a side effect. So yes, you have to use it in the right patient population, meaning like I cannot give it to someone who say has had pancreatitis 3 times because of some reason, whatever it is, okay? Except where there was a modifiable factor, meaning someone had a gallstone, it got taken out, resolved, move on. There are certain genetic conditions or syndromes that it cannot be given in, and we would not prescribe it even if it was whatever. It could be helpful, but the caveat is we don't know what potentially could happen there. Common side effects. The most common is gastrointestinal side effects, meaning nausea, abdominal discomfort, bloating, constipation, sometimes the opposite, diarrhea. And how do you mitigate those? My go-to analogy is think about the lazy river. You all know what a lazy river is, right? If you have a lazy river, you're just going to walk slowly. That's how the food is going to move. So instead of the food leaving your stomach in 3 hours, which is typically 3 to 4, it might sit in your stomach for 5 to 6 or even longer. That's what the TikTok world calls gastric paralysis. This is the effect of the medication. So how do you mitigate that? Eat only when you're hungry, not because the clock says it's time to eat. That's how we have been conditioned to eat. Breakfast at 8, lunch at noon, dinner at 6, or whatever it is. And then staying hydrated, drinking enough water, protein intake, which will keep you fuller and also prevent lean mass reduction. Because a lot of times when people initially lose weight because they're not eating, they're losing a lot of fat mass and muscle mass. Exercise regularly, take enough fiber so you're not constipated. Those are the ways to mitigate those side effects. Rarely, and with tirzepatide, sometimes people can get like what they call paresthesias, where they feel that skin reaction, where they feel that something is crawling on their skin. It's what we call an idiosyncratic reaction, meaning it's not something that you commonly see, but can happen. Sometimes dose reduction has helped. Sometimes using antihistamine medications has helped as well. Other than that, where did it go? Did I miss that slide?
The very first one.
Is it the first one?
Yeah.
So then coming to another major aspect of these medications, like hypoglycemia. Hypoglycemia means low blood glucose. And anything that is less than 70 milligrams per deciliter of blood glucose is called true hypoglycemia. And who is at increased risk of hypoglycemia are patients with diabetes who may be taking additional medications like insulin or, like I first said, sulfonylureas. In those patients you may see, so if you start the medicine, you counsel them that you have to make sure that you keep testing your blood sugars so that we can adjust your medication downwards. That way, you will prevent that or mitigate that particular side effect. Now, you would say that if this medication in conjunction with insulin and other pills that we use for diabetes can cause low blood sugar, why does this not happen in people who do not have diabetes but are taking it for weight management purposes? Because these are what I call, just like our smartphones, smart medicines. They look at your glucose levels and then adjust it accordingly. So the people with no diabetes will unlikely have low blood sugars. And as Dr. Abraham already suggested, these medications are considered lifelong. You don't want to lose vanity pounds for a marriage and then stop it. You will gain all that weight back. These are long-term medications, mostly safe. Yes, you have to have the right patient population in order to decide who is the right candidate for this medicine. And absolutely, discussing this with your physician, whoever it is always the best way to decide on if a medicine is good for you or not. Now, the South Asian population, is this medicine something that can benefit our South Asian population? In my opinion, I find it very, very useful. Yes, there are certain side effects. Yes, there are concerns about weight loss. But even in people who may not need to have a whole lot of weight to lose, you can see an improvement in their insulin resistance, in their metabolic markers. So my go-to when I find that I have not much in terms of offering except insulin is to trial GLP-1 receptors, and more often than not, I have had good results with these medications. With that, I will conclude and I will pass it on to Shivani. Thank you.
Hi everyone, my name is Shivani. I'm a licensed pharmacist for the state of Kansas, and Dr. Abraham and Dr. Bond did a really good job of going through what I will be going through as well, just mainly talking about the benefits of GLP-1s, the risk, and the long-term effects. So what we've already went through is the benefits of GLP-1s, how GLPs target multiple metabolic pathways simultaneously, rather than just lowering your glucose. And so as you can see here, we reviewed about the different receptors that are seen around our body, in our blood vessels, our pancreas, our intestines, our brain, our heart, and our kidneys. And so with having this effect, we were talking about, those with diabetes are prone to having increased stroke, increased heart attack, increased blood cholesterol. So it's a condition that affects multiple systems. And so when you have GLPs, as we reviewed, they affect and help improve cardiovascular risk factors, including A1C, your blood pressure, your cholesterol, reducing inflammation, and helping store fat. And it also is contributed to many, again, cardiovascular outcomes. And at the end of the day, it also helps slow the progression of diabetic kidney disease and support long-term cardiorenal health. And out of any, when counseling patients from a pharmacist perspective that I've seen, no other medication in the market is really helping improve or sustain these pathways. And so that is kind of like my number one recommendation on starting or at least trialing GLPs. We haven't really talked about it yet, but even in our diabetic ADA guidelines, it used to be metformin was the number one recommended treatment for those with diabetes. Now recently they changed it a few years ago, making GLPs and SGLT2s as the recommendation for treatment. We didn't really talk about SGLT2s, but you probably have heard of Jardiance, and that medication helps your sugars release through your urine. And it's very effective, also very effective when it comes to cardiovascular benefits as well. But with GLPs, what I counsel patients on is this is a once-a-week medication. You know, when you take medications, side effects are important, of course, to assess, as well as their benefits. But if you're not adherent to your medication every single day, you're not going to see a benefit. So I know life happens, right? Like you forget to take your medications, or there are days where you don't feel like taking your meds. But when you think about this GLP, it's once a week. And so you have more of that comfort and that control of knowing you just have to take it once a week to help reach your goals when it comes to improved A1C, reduced blood pressure, and reduced risk of cardiovascular events. So going on to risk, we kind of already talked about this. Side effects from GLPs are nausea, vomiting, diarrhea, and that decreased appetite. I will say, when counseling patients, I've heard them say, hearing these side effects of nausea and vomiting. But my biggest question is talking about their diet. A lot of these patients that start are continuing their diet as they always have been. They haven't really assessed like, oh, should I be changing my diet? Should I really be listening to my body and understanding what my brain is saying when it comes to, not eating as much? So it really is following and understanding what your body wants. And so a lot of times it's that. A lot of times it's also, endocrinologists do a really good job of monitoring patients, making sure they start at the lowest dose before titrating. So you start at the lowest dose, you have follow-up appointments with your endocrinologist, and they assess how you're experiencing these side effects. If you're tolerating it well, give it 4 to 6 weeks, and then they'll increase the dose to maintenance. And so it's really important to titrate slowly to mitigate side effects. We kind of already went over like the uncommon risk as well, like pancreatitis, gastroparesis, like low blood sugars as well. These are instances that we would avoid GLPs if you have a history of, as well as thyroid cancer warnings. If you have any family history of medullary thyroid cancer, it is recommended not to be on this medication. And so those are things that your doctor is constantly assessing before starting treatment. Long-term effects, as you take GLPs, again, your doctors are still monitoring, but as you take, it is known to reduce muscle mass over time and nutritional deficiencies as well. But what's key here is ensuring you're getting adequate calcium, vitamin D, B vitamins, and overall, making sure you're eating nutritious foods, even if you feel full. We want to make sure we're optimizing your nutrition, even in these low-calorie diets. We want to also continue exercising, right, to help improve that lean muscle and bone density as you lose weight. And we want to also, continue following up. Just because you're on these medications, you're maybe only having to take one medication for diabetes, you want to have continuous follow-ups with your doctor, no matter how good your A1C is. And then lastly, just continue lifestyle habits, exercise, as that also plays a key role in reaching your goals.
Good afternoon. So we have heard from endocrinologists and PharmD about all the effects, but ultimately it boils down to nutrition, right? How much we eat. So little bit on, I know in the next 5 to 6 slides, I won't be like tell you everything about nutrition, but important aspects of in relation to the drugs that we have talked about. Let's see. So the 4 focus points of our obesity treatment, we call it as 4 pillars. Definitely, we have seen nutrition therapy would be the first one or one of the 4 pillars, and behavior modification, and physical activity, and then medical interventions. The medical interventions we already talked about, and then we're going to discuss the physical activity after we talk about the nutrition therapy. So these are the 4 most important pillars in order to effectively utilize that medications that you're taking. So, you have to follow all of this behavior modification, even the stress and all that that we have already covered. So coming to the nutrition therapy, I know some of them already touch based on like what are the side effects of these drugs, right? So first and foremost would be that we need to look into the protein, because when the intake decreases, obviously the medication is working, so you decrease the intake. With the intake, definitely the protein intake also goes down. So the first and foremost is that we need to make sure at least getting about 60 to 75 grams of protein per day. That looks like a lot of protein, but in the next slide I will show like how easily we can meet that. We don't even have to do a lot of protein supplements, protein powders. But another thing is the hydration. Fluid is the key. You have to have that fluid intake 2 to 3 liters per day. One thing that we need to consider is that we may want to space the fluid intake between the meals, not with the meals, so that you're not getting full with the fluid intake itself. So try to consume fluids between the meals, not with the meals, so that you're getting ample amount of your protein and whatever amount of food you're eating, you're getting the nutrients through the food. Fiber, because of the constipation, 21 grams per day for females, more than 30 grams at the minimum, more than like minimum at least 30 or more grams per day for males. Important point here is that the fiber also keeps you full, so that you're not going after other foods. Like once you have your meals done, then you are not looking for other crunchy munchy snacks and then increasing those calorie intake. So including the fiber-rich foods along with your meals would benefit that as well as the treatment. You're taking the medication, you want to see the fullest effect of that medication. One important consideration that we want to focus on is the vitamins and minerals, regardless of Ozempic or any other GLPs or not. A vitamin and mineral deficiencies are very common in our community, especially the iron, B12, because of not eating the meat items. That is where the deficiency surfaces. And also tea, right? We are drinking so much tea all the time, chai. That inhibits whatever iron coming from the food, the tannins and polyphenols, not mostly the tannins present in the tea inhibit the iron absorption. So if you have to drink the tea, at least space it out an hour or 2 after the meals, especially if you are not a meat eater. In that way, we are getting enough iron. Also, like combining iron-rich foods with vitamin C also helps. But most important thing is that decreasing the chai intake. Along with the chai, you got the milk and sugar, right? Vitamins and minerals, I'll focus on that in the next slide, because these are the one of the things that we need to look at, especially if you're decreasing the calorie intake. Definitely looking for a vitamin and mineral supplement would be beneficial, especially the calorie intake is about 1200 calories. It's really difficult to meet all the important vitamins and minerals with that 1200 calorie meal pattern or 1500 calories when it comes to meals. So energy intake, in order to keep, it is not just during the medications for Luckily, if you get off the medication, you have been adhering to the diet and physical activity, and you control the hemoglobin A1C. So, and doctor says that you don't have to continue anymore. Then the key is that once you get off the medication, sticking to that energy restriction is the key. Otherwise, again, you have to go back on. So, and maybe you won't be able to get off the medication at all. And, yes, diabetes is a lifelong thing, but you also need to control that with nutrition, right? So 1200 to 1500 calorie meal pattern for females. It doesn't, for anybody who wants to maintain the weight, I think would be a good starting point. And for males, 1500 to 1800 calories per day. So that will be the starting point, or sticking to that would be a good goal, so that we are not gaining too much of weight and accumulating those pounds and then needing that anti-obesity treatment drugs. So nutrient deficiencies, I also mentioned in the previous slide, right? So we have, along with these medications, you might patients might feel like fatigue, excessive hair loss, skin flakiness or itching. Is not just because it's because of the medications, it's mostly because of the nutrient deficiencies the body is suffering from. So one of the things that you're looking at, I already talked about the iron, which is iron deficiency anemia, and that can cause fatigue and shortness of breath. Calcium, we drinking tea, but it doesn't give that much of milk. Then we need at least 3 cups of dairy products a day, either dairy alternatives, soy, or whole milk. Not whole milk, but the regular milk. It can be a skim milk. But the milk and dairy products need to be at least 3 cups a day. And then yogurt, and of course we are eating a lot of yogurt. But again, when you are eating yogurt with the meals, it may be like 1 spoon of yogurt, and they say that yes, I do eat yogurt, but it's not eating yogurt, it's the quantity of how much you eat is important. So now in the market, we got a lot of protein-rich yogurts available, so you can have it as a snack, not just with the meal. Okay. Magnesium is another deficiency, is most common in the patients that are using the GLPs. Again, you'll see like a lot of muscle cramping, and also like a numbness, or sometimes they may feel like swelling happening in the feet. So again, you don't have to take these supplements, but at least every 6 months you need to make sure your levels are normal. So when you go to the doctor, the primary care provider, make them ask them that they would be tested, because you have to get your blood test anyway, yearly blood test. So getting these tests is very important. And then the zinc deficiency, because zinc is very high in the meat products. So when a patient, if you're not consuming meat, then there is an increased risk for developing zinc deficiency. And there are food products higher in zinc values, but then the fiber, if you're combining the vegetable sources and the zinc, sometimes each other can inhibit each other and then make it unavailable to the body. So taking a zinc supplement would be beneficial as well. However, if you take too much of zinc supplements, it can contract with the iron absorption. So first and foremost is that before you go to the supplement store and buy all the supplements today, this evening, make sure you have actually a deficiency and that you need those zinc supplements or iron supplements. Okay? Other vitamins, you're looking at fat-soluble vitamins, because if you're decreasing a lot of fat intake with these medications, then these vitamin A, D, and K, they really require the fat for the absorption. So as a result, the availability of these vitamins will also decrease. B1, B2, vitamin C, these are the water-soluble vitamins, and we do need them regularly. Every single day we need to take them. Okay, so some of the nutrient deficiencies, and these are most commonly published, like deficiencies that are published in the literature with these medications, so anti-obesity treatment related nutrient deficiency. So again, we have to make sure you have the deficiencies before you take the supplement, and that means that you need to get the blood test done at least once a year to keep going. And vitamin D is very common in our Asian community, vitamin D deficiency. That's the reason why we have to make sure we get those blood tests. And these are not the routine blood tests that will be done with your CMP and CBP. So it is like specifically the doctor has to put in this order for you. So talking about some of the diets, right? So I talked about 60 to 75 grams of protein. This slide, I really like it because, the high protein diet versus high carbohydrate. When you say high carbohydrate, the percentage. This study was done in type 2 diabetic patients, 20 to 60 years age, with a BMI of more than 30 to 55, where one group consumed a 30% of calories coming from protein. These are all calorie restricted. They are not consuming 2,000 or 3,000 calories here. They are a calorie restricted diet. Even in that calorie restricted diet, they have up their higher protein intake. So looking at that, on the red bars here, with the protein diet, high protein diet, you see that the fat mass was decreased 2.9%. Similar, the high carbohydrate diet also had a higher fat mass, only a little bit higher, 3.3. However, when you look at the lean mass, the muscle mass, high protein diet had actually improved by 2.7% increase in the lean mass, whereas in the high carbohydrate, the lean mass actually dropped. Okay, so they're losing the lean mass. So that's the reason why we talk about the high protein is very important. At least make sure we get 60 to 75 grams of protein a day in order to preserve that lean body mass. One thing that we need to look at is what is the importance of having that lean body mass, right? The muscle mass is very important, especially with the lower extremities. For the gait, the balance, we don't want to fall and have the fracture risk. So that muscle mass helps provide that strength. So it's very important to have that protein in the diet. How does a protein, like 60 gram protein diet look like? 6 a.m. Again, it's all about lifestyle modifications here. I know you're like, some of them may not do like 3 to 4 meals, but it is about having frequent small meals is a critical thing. And again, you have to make sure you're modifying the lifestyle here. And so at 6 a.m. when you get up, you maybe have to get the 12 grams of protein, it's just 1 cup of skim milk and like a handful of almonds or walnuts. Those are the rich source, nuts wise, they're healthier nuts compared to peanuts, cashew nuts, or pistachios. Okay, so we are more prone to eating peanuts, right? So walnuts and almonds are the healthier sources. And also they have higher omega-3 healthier fat sources. And then at the noon, before lunch, you can have like a peanut chutney or hummus, and with 1/3 cup hummus, which provides about 5 grams of protein. 3 small idlis, like the small idli, not like the restaurant size idlis, but the small idli, 3 small idlis would give that 10 o'clock, meal. Again, this is all about not eating a whole lot of volume at one sitting. It is like consistently eating smaller portions that would help with that spikes. Cucumber slices have no protein. So it is like just getting that, idli composition also we are putting dal and rice or rava, right? So you will have a little bit of protein in that. And at noon, 1 cup of rajma, or like the yogurt, you can have that cucumber and onion salad with a half a cup of yogurt and salad. That all comes back to additional protein, about 18 grams. Rajma is the protein source here, which is also have fiber. So that is where you're looking at how much to get and what type. And again, I made it like, it's not, lunch is all vegetarian here, no meat in there. At 2 o'clock, again, cottage cheese is a best, excellent protein source, non-fat cottage cheese. And then you can put some pineapple chunks in there or mango, like little, not too much of an entire mango, vanginpalli type, just like half a cup of mango into your pineapple chunk. And little whole, like 5 almonds, I will give you protein. That cottage cheese has got an excellent, so it's an excellent source of protein, 1/3 cup. You don't even have to have half a cup or 1 cup of cottage cheese. Just 1/3 cup would provide that much of protein. And low carbohydrate source, cottage cheese doesn't have that much of carbohydrates compared to the milk. Okay. And at 6 p.m. again you go to like chicken or fish because those are the, I don't have to worry about the beef and the pork in our community. So the chicken and the fish are the best sources, the lean meat sources. And then have a cup of rice and cooked vegetables. You can do as many, but it's not like a potatoes or sweet potatoes or corn type. So the dark green leafy vegetables. Cooking, I know vegetables, we all eat vegetables, but how we are preparing the vegetable is the key. A lot of people ask me like, okay, olive oil, avocado oil, or peanut oil. Yes, it's not the oil, it's the amount that you use, like 10 spoons of olive oil versus 1 spoon of peanut oil. The olive oil benefit will not be there because it's a fat, it's a fat, it's a fat. So the combination, so if you're using the same amount of oil, we will go with avocado oil, or olive oil, but again, going back to that, cooking the vegetables is where how you cook them, steam. We got that, our culture, we have like, you have to fry the vegetables to death, right? So it's not that we don't see any color, but the time from the table to the pan and then comes back to the table when the cooking range, the color from dark green it becomes brown or something black because of the cooking process. So we fry them and bake them, whatever. So having that natural, preserving that natural color in the vegetables right from the market to the table would be a best option. That is a healthier way to do it. Okay, so again, this is our lifestyle. We have done it for past 20, 30, 40, 50 years, and it's really difficult to change. But again, with the medications, we have to do the lifestyle change as well. So the plate method, we have talked about healthy plate. Here you can see that fruits and vegetables, like half of the plate will be fruits and vegetables. However, you can keep that fruit as a snack and then have half the plate as vegetables during lunch or during dinner. In that way, it gives that fiber and feeling of fullness as well. Whole grains, 1/4, and then the healthy protein, the meats or the rajma and all, or come under the other 1/4. We have the thali. Our thali is like 4 or 5 katoris in there, and this big portion, half the portion would be rice or chapati in the bigger area, and then the smaller areas would be like little bit dal, little bit curry, little bit this, and all the healthier options would be small katoris, and the rice and roti would be the bigger other half of the plate. So trying to flip the plate and then eating the healthier portions, a larger amount, and cutting down on the carbohydrates. Would be the key. Again, it's lifestyle choice. Water is important, hydration. You can go with different kinds of fluid. Tea is a fluid, coffee is a fluid, but the thing is water, it's a 0 calories, right? You need to get that water going, and then again, between the meals is important. Then with the meals, especially if you're cutting down on the intake of the food and when you don't have that much of an appetite. Whole grains, oatmeal, quinoa, like whole wheat, all that more important than going with the white rice. And a lot of us are changing the habits to go with the whole grains instead of eating the white rice and other white wheat or regular wheat products. Bleached wheat, you can say, or maida. Healthier proteins, which I already talked about before, and protein is very important. At least 1.2 grams per kilogram body weight is what is needed. Or if you don't want to calculate that, at least make sure 60 to 75 grams of protein. Again, going with the body weight range would be the best option. Then you are meeting the protein requirement based on the body weight. And looking at the fruits and vegetables, as I mentioned before, as much like fresh ones, unprocessed would be better. Healthier fat, we already discussed about the fats like olive oil, and also moderation, right? Moderation is the key. Doesn't matter what type of, if you're just used to doing the peanut oil, cutting down on the frying and cutting down that tadakas, putting like 4 or 5 chamchas instead of just do one, a little bit needed, and then go from there. Okay, I know you're laughing at how can you do a tadka with 1 chamcha of peanut oil, right? So again, it's a lifestyle. It goes back to lifestyle and adapting to the new ways. So I think that is what I have. Yeah, and then like beyond, okay, so time restricted eating, intermittent fasting, you must have heard all this. I'm doing intermittent fasting. So intermittent fasting is itself has got a time restricted eating or energy restricted eating, okay? Early time restricted eating, there are different ways. It will be like a 14 hours of fasting and 10 hours of eating window, or there is like 10 hours of, no, 12 hours of fasting and 16 hours of fasting and 8 hours of eating window. Okay, there are two types. The key is doesn't matter just because you're doing like 14 hours of fasting or 16 hours of fasting. Other 10 to 8 to 10 hours cannot be like 3,000 calories or 4,000 calories, because we are going to fast rest of the 14 hours or 16 hours. It has to be energy restricted fasting. That is the key. Okay, that is where you see a lot of health benefits, is because keeping that energy restriction, calorie intake with the fasting, you have a lot more benefits. So with that, there are a lot more of like advanced like side effects, especially irritability is one thing you often see with the 16-hour fasting. Palpitations or dizziness, especially with the diabetic patients, some of them may not work this type of fasting with the medications, 16-hour fasting. And also like when you have to go out with the social gatherings, Friday night, Saturday night, Sunday morning, lunch, brunch gatherings, that may not be, it will not fit into that. So you have to make sure it is fitting your social pattern as well, eating patterns. And also each one has its own side effects. But however, the bottom line is it's not just fasting, it is about calorie restriction along with that fasting, time restricted eating. It's not fasting, but time restricted eating of 16 hours or 14 hours. So that kind of finishes my talk. Okay. So yeah.
Go ahead and stand and speak. Good afternoon, everyone. So we'll now talk about physical therapy, obesity, and diabetes, and see why is exercise actually just important? Why is in general exercise important? There's so many benefits. You all probably know about it already, but long-term management, because it burns the calories. And our whole talk has been about obesity, has been about diabetes. So the very first benefit of this is weight management. The second one is, if you exercise, the muscles are more active and they absorb the glucose that is floating around in the blood and help lower the blood glucose levels. Along with that, if you're doing it, definitely your A1C is going to come down lower. Along with that, you have more reduction in the fat mass if done correctly, and probably we can maintain the muscle mass, that is more important. If your muscle is maintained, muscle mass is maintained, definitely the bone health will be better, because when muscles contract, they make the bones also move and bone health improves. And along with all of those benefits, we also have benefit of having improved mobility, especially for the elderly people, maintaining balance, reducing the number of falls, especially in elderly. So what is the exercise recommendations actually for obesity and diabetic population? So it is recommended that you exercise at least from 150 to 300 minutes per week of moderate intensity aerobic exercises. So your aerobic, we'll talk about this in a little bit more detail, what does constitute an aerobic activity and what is a resistance activity, but aerobic 150 to 300 minutes per week. Along with that, you want to go ahead and do resistance exercise at least 2 days in a week. 2 days with weights, with resistant bands, your own body weight, resistance exercise for 2 days at least, minimum in a week. Along with that, you want to go ahead and do some flexibility and balance exercises. And flexibility, you could choose to do anything, yoga, tai chi, pilates, anything that you're more interested, or general body stretching exercises. If you sit for a long time, more than 30 minutes, you have to get up at least, the recommendation is get up for at least 3 minutes every 30 minutes. And here in this session, it has already been more than 1 hour. It is 1.5 hours we have been sitting. So let us just all get up. Let us get up and just do some stretches. Right? It's been long. Go ahead and let's just do some neck rotations. If you have any neck issues, please do not go ahead and do it. But let's do some neck rotations round. Both ways. Go ahead and do some shoulder moves. Both ways. Some wrist rotations. Again, both ways. For our lower extremity, let's just do marching. A little bit bigger. So it stretches and you have more range of motion. A little bit more. Go up all the way. Go up all the way. Good job, you all. Good job. I know, right? Let's do some ankle rotations. Both sides. Careful, one hold on to something. Absolutely. Balance is very important, yes. The other leg. Nice. So let's do something for the back. We didn't do anything for the back, right? So let's just do some rotations for the back. Awesome. Great. Sounds good. Okay, let's move further. Okay, so just a quick summary. We have to do every week 150 to 300 minutes of aerobic exercise. Along with that, 2 days of resistance at a minimum, 2 days. We have to do some flexibility like we did stretching and all. And every 30 minutes you should get up every 3 minutes. Every 30 minutes you have to get up for 3 minutes. So here are some examples of the aerobic activity. The yellow bar that you see, the first yellow column, that one is very light. It's not going to do much. So you want to be around this color, which is green and blue. At least walking for 3 to 4 miles, scrubbing floor, gardening. Then we have golfing, mowing the lawn. Those are some good activities. And you also want to be a little bit more aggressive. And some of the aggressive ideas are, again, biking maybe 10 to 15 miles per hour. Walking even more brisker, maybe running 6 miles per hour. And you can see here all the examples of doing more vigorous exercises. So if you do moderate, like this one on the back slide, if you do moderate in the green and blue column, you should do 150 to 300 minutes. If you do more vigorous exercises, like here on this slide, you should do it only for 75 to 150 minutes per week. So that is the recommendation. If you do moderate, time has to increase. If you do more vigorous, then only 75 to 150 minutes. Okay, so we saw such good benefits of GLP drugs. Dr. Bhan went over all of the drugs and its benefits and side effects. And we saw that there is so much weight reduction with these medications. 25%, 20%, right? Or maybe even more with some of the drugs. So there is weight loss that is very significant. However, 25 to 40% of the weight loss can actually just come from the skeletal muscle mass. So you're actually losing the muscle. So about 60% maybe from fat loss, about 40% maybe from losing muscle. And you do not want that, right? You do not want to lose muscle. If you lose muscle as more prominent part of weight loss, then it is called as sarcopenia. That's the medical term that is used. Why do we want this muscle mass? The benefits are very similar to what we have already talked about. You need the muscle mass so you can maintain the bone health, improve metabolism, burn down more calories, mobility, balance, strength, right? We all saw for all exercises you need to have balance, you need to have strength, you need to have mobility. Greater glucose control, also definitely reducing the inflammation. Here panelists talked about obesity leading to inflammation. You do need muscle mass to prevent that inflammation. And also, in general, you are living longer, right? Extra life that we get. Okay, so with GLP medications, definitely there's weight loss we saw. Along with that, what do we want? We don't want just the weight loss. We want healthy weight loss, right? And how can we do a healthy weight loss? When we lose only the fat, but we do not lose the muscle. Okay, so what is recommended for that? All recommendations are that you do more resistance exercise along with the aerobic exercise. So you cannot ignore the aerobic exercise, but you have to do resistance exercise. A lot of focus should be on that. Okay, so what do you do when you do resistance exercises? You have to do it consistently. It's not 1 week, it's not 2 weeks. It has to go for months and months until you are taking medications and even after that. So because you will put on weight, panelist already said, you will put on weight as you stop medications. But you should not stop exercise, that is the recommendation. You have to continue with the resistance exercise, more focus, along with the aerobic exercises. Okay, so consistency. And then you have to gradually increase the overload. Maybe if you can do 10 reps, not necessarily the other person can do 10 repetitions as well. So progressively, watch for your body and then increase either the weight or the repetitions and gradually work. Keep on overloading your muscle basically. Okay, so there's one more thing. Why do we say 2 days per week? At least 2 days per week. Because whenever you do resistance exercise, there has to be a break in between. You should give at least 24 hours before you do the next session. Otherwise, your muscle will not recover. So at least 2 days, 3 days are more recommended. 4 days, that you could also, even if you do 4 days, you could still somehow have 24 hours in there. So some rest so your muscle can recover and grow. Basically become have more strength, have more muscle fibers. So 1 full day of rest. Along with that, Dr. Mandali already talked about hydration. So important. Protein intake is so important along with resistance exercise because your muscle, when you're building muscle, you need protein. Muscles are made up of protein. So you need that. And sleeping. Sleep is very important. You have to take 7 to 8 hours of sleep. If you do all this trying to make muscle, eating, still not sleeping, it's just not that effective. Sleep has shown so much of effect on your body. Okay, then what do we have? These are some examples of resistance exercises. So the first column here, the first vertical column, the first 2 vertical columns that talk about upper and lower body, you can see that they are just using their own body weight. So you could do resistance exercises with just your own body weight. Squats, lunges, there's so many examples, planks, crunches, step ups, step downs, up and down the stairs. There's so many examples of just your own body weight. You do not even need anything. On the right, you can see that maybe you have dumbbells at home or maybe you go to the gym and you could do similar exercises using these dumbbells as well. So some examples of those. You could do the same with resistance bands. And if you really see when we are talking about these examples, it's the big muscle groups that you have to target. The bigger muscle groups. Your glutes you have to target. You have to target your hamstrings. You have to target your quadriceps. You have to shoulder muscles, elbows. You have to just go for bigger muscles because when you start to lose weight with these drugs, what happens is you also are losing the muscle and it causes that loose skin. Like even when we are pregnant and we deliver the baby, how the stomach becomes, the skin stretches and when you lose, it just becomes elastic, non-elastic and stretched. Yeah. So that is also one of the side effects of those drugs that you could see. When you lose fat, you lose muscle, the skin just appears looser. And especially, there's a term that the internet coined term for Ozempic butt, right? It's you lose the fat from your glutes, and it's just the loose skin that can be seen. Okay, in summary, so with these drugs, we are doing resistance exercise and we are also doing the aerobic. With resistance exercise, always whenever you start, give 5 to 10 minutes of warm up, walking, cycling, you could just do light cardio. You can do stretches during warm up, and then also the cool down, you could do stretches. 2 to 3 days per week, because you want to give 1 day at least in between as a break for the muscles to recover. So maybe you could go for Monday, Wednesday, Friday, or something like that. And then keep on increasing the sets as you keep getting better. There's nothing called as you have to do 10 times only this exercise. There's nothing like that. If you could just do 2 times, go ahead with 2 times. Next time, try to do it more. So everybody is different. It is recommended that you do at least 20 to 45 minutes of resistance exercises. And gradually make it hard to very hard. So maybe you can talk. Very hard is maybe you can talk, but you cannot sing while you're doing exercise. That would be considered as very hard. That you're not able to sing, but you're able to talk with, breaths in between. So that would be very hard. So gradually you have to go to that very hard that you're not able to sing or talk while you're exercising. So to gradually get to that, but do it gradually. It's never one day, right? Okay. Then what do we have? Yeah, I think that is it. Keep on increasing the reps as you get better and better with those exercises. So both of them, resistance, aerobic, both, but more focus on resistance with the GLP drugs.
Do we have any questions from the audience?
You take the mic around.
Yeah.
This is more related to those fitness devices. I've read about this Hume band, which talks about metabolic rate measurements, and it even said that it can detect a heart attack much early. How true is it, and is it really worth us investing money in it?
So, you have lots of devices. I mean, Hume has been just on the market, in the recent, last year or so, I believe. I'm not entirely familiar with it, but I just happened to see something yesterday with the pen. So I was interested in looking at the statistics of what it looks at. And there's a lot of data over this. I could agree. Hello? Yeah. So specifically since you asked about the Hume band, there is a lot of data in there. When you look at the app, lots and lots of data. But how true is it, or how useful this will be in the long term, it's hard to tell. Now, you look at the Apple device, you have the Fitbits and all. We have seen benefit from these devices. There have been instances where they have picked on irregular heart rhythms and sought care for that. So yes, there is certain benefit in those, but I don't think we have to rely generally just on devices for how we need to change our habits.
We have a bunch of questions. One, probably more for your endocrinologist. How does perimenopause, menopause, or postmenopause affect sugar, and why does it increase sugar levels?
There are a few things to look into menopause, perimenopause, time frame. I think more than the phase that you go through, what happens is as we start going through perimenopause and menopause, we lose a little bit of bone mass and lean body weight because the estrogen starts going down. Estrogen is what we need for muscle, bone strength, and things like that. And if we look into how the sugar metabolism works, if you eat as the sugar comes into the blood, liver takes some of it, muscle takes some of it. And of course, the insulin will help the sugar to go into any cell of the body, right? Now, as you're going through perimenopause, actually postmenopause more, but in even years prior to going through actual menopause, our body goes through those lean body changes. And now when you see the lean body is changing, the muscle uptake of the sugar goes down. And so the sugar starts rising. It's not because your menopause is directly causing anything to the diabetes, but there are indirect ways for why your sugars start going up. And that's where the exercise and everything comes into picture, because you are improving the lean body mass. And this you should start way ahead. Don't wait until you get to that phase, because then you probably may be too late. You want to build up, have that habit ahead, so your muscle and bones will take the glucose and improve your insulin function, and thus helping your diabetes. You guys want to add more to what I said?
So I had read that you reach your maximum bone density around the age of what, 24, 26? Peak. So you want to really encourage the younger women to exercise earlier to help build that up, so it's lesser as you age. Second question, what test is done to check insulin resistance?
Wow, actually, you don't need a test to check insulin resistance. We heard that by genetics, we all have insulin resistance. Insulin resistance simply means the body cannot process the available insulin. So you will know, you will develop diabetes, right? So there's no one test to check for insulin resistance. So how do we improve insulin resistance, or how do we change that? Exercise. So with exercise, our body will be able to use insulin much more efficiently. Just like we did our little exercise. We should all be standing actually, right? So any movement, any physical activity will help our body to use the available insulin much more efficiently. So there's no one single test for insulin resistance.
Excuse me, I'm Dr. Ismaili. I do work with elderly patients, and I've been practicing the insulin resistance for the last 20 plus years, so I can answer that question. For general, audience, how do you measure insulin resistance? We look at the patient, then we know, just by looking at. Earlier, Dr. Patel mentioned about the 36 pant size. That's supposed to be normal size. For us, it's lesser than that, 34, 33 pant size. We look at it, somebody is lean, but they got a belly. That belly circumference more than the 34 inches is a sign of insulin resistance. If somebody is wearing a collar, like a work clothing shirt, a regular shirt that's a tailored shirt, if they are wearing more than 15 size collar size, means they have thick, big neck, that's a sign of insulin resistance. There are signs, some people have this dark discoloration around the neck area. Skin changes, it's called acanthosis necrosis. Or underarms, they get dark pigmentation. Before that, they don't have it. In the face, all of a sudden, they are having these dark spots. And you can see in the neck, in the armpits, in the groin area, that's insulin resistance. And their blood pressure starts going higher. Before they did not have that problem. Now they are having blood pressure problem. And their cholesterol levels, their good cholesterol starts going down. Bad cholesterol going up. The other one you might have heard about, triglycerides. That starts going up. I'm a general practitioner, so these questions, I answer them. That's why I'm able to answer what the general audience, the specialist, they don't get these questions that often. So these are the signs. The minute we look at the patient with a little bit rounder belly, thicker neck area, they are lean legs and arms, means they don't have any muscle. All they got is the fat around the belly. So, and the blood pressure is higher, just like earlier I said, trophy. Thin outside, they look thin, but fat inside means fat in this core, abdomen area, around the liver, around the stomach, around the heart. Thank you for letting me answer. Skin tags. A lot of you see around your necklace area, there are small, areas of muscle. You can just pull them. You go to the doctor to remove those. We call them pulpari in Telugu, and here they call it as skin tags. It's because of a viral infection in overweight people, and the insulin resistance increases it. They get a lot of those skin tags around the neck area, in the underarms area. So those are the signs that I know of.
The next question about not having insulin resistance with menopause and fluctuating sugars has already been answered. Another one is, how do GLP medicines affect hypothyroid or the thyroid? Is it safe to take GLP-1s with hypothyroidism?
So, GLP-1s with taking thyroid medications is absolutely safe. You just have to make sure that you keep taking your medicine correctly and consistently. There are instances where sometimes we do see need for adjustment of medications, and that could be due to delayed absorption as well. There have been times where I have needed to adjust the dose upwards or downwards, mostly downwards, because when you lose weight, thyroid is a weight-based medicine. So if people lose or gain weight beyond a certain point, they will need to have that dose adjusted, but it's absolutely safe otherwise to take the medication.
And as you said, and as Dr. Ban said, GLP-1 agent, we see how it slows the movement in the stomach. Now, thyroid medicine, it's very sensitive to how you take. As we all know, we say, take it first thing in the morning, wait before you eat. The normal, common advice the doctor will say, wait 30 minutes before you start eating. Now, you know that your GLP-1 agent, your stomach is moving slowly. Maybe you may want to take it a little bit more than 30 minutes apart from food. Or sometimes I commonly tell people is thyroid, like middle of the night, if you wake up and go to the bathroom, if you can remember that and not forget next day and mix up, maybe that would be a best time to take a thyroid medication. Your stomach is empty, movement is not too bad, your GLP-1 mobility will be there, but you've taken it way ahead before you start eating, that the absorption and variation may not be as bad.
The other thing about thyroid medicine to remember is not to take it with any of your minerals that you take, because it binds, especially iron, magnesium, calcium. It binds to metal, so don't take it either with food or with your supplements. Separate it out by about 2 hours. Other questions. How does metformin compare with lifestyle changes and diet for diabetes prevention? Does anyone wish to comment on that?
Yes, it does, the short answer. And there is nothing wrong with taking metformin. You'll see a lot of negative press about metformin. Like every third week, we have people wanting to come off of metformin because they've seen something on the internet. And yes, remember, before anyone is diagnosed, especially with type 2 diabetes, they've had pre-diabetes or impaired fasting glucose for years before, up to 10 years before. So if you can do something about it then, so that you don't develop over diabetes, is your best option. And you don't have to be on a full dose. Sometimes just 500 once a day is a good dose that can prevent. Of course, with lifestyle changes, you've got to incorporate those as well. So short answer, yes, you can. That is absolutely an option as long as you're able to. There are no what we call contraindications, meaning that you shouldn't be taking the medicine, or if you're not experiencing any side effects from the medication. That, yes.
I read it in some scientific magazines. You heard about GLP hormone, the Gila monster. It has that hormone. We also secrete that hormone. Metformin helps you not to break down that hormone. So we already have some. But when we are overweight or diabetic, that hormone becomes very inactive. Metformin makes it more active and not get breakdown. It also makes your muscles take up the sugar to break it down. That's why it is important to stay on metformin, unless, as Dr. mentioned, as Dr. Bhan mentioned, kidney disease or you're having CAT scan, something like that. So that's when you should not be taking. Otherwise, it's one of the best medicines. Even in cosmetology wise, they are saying who are on metformin, they look younger than. It prevents cancer, so many benefits with that medicine.
Another one. Can you share more insights into fatty liver and how it can be mitigated? What lifestyle changes can help reduce this?
Again, fatty liver also the best treatment is weight management or weight loss. So it comes to basics, lifestyle change, healthy eating and exercise and weight management. And GLP-1, the medication that we talked about, the family of Ozempic, there are a lot of studies going on and they are being effectively used in the management of fatty liver also. And we may get more and more indications, getting approval in the same family of medication to treat fatty liver also. So bottom line is still lifestyle change.
I was asking questions in a different doctors group that works in the research side. And Dr. Pandya is one of our liver doctors in town. I talked to him 4 days ago about these GLP drugs to gather more points. He said, our health insurance system is so bad now, they are paying thousands of dollars to do a colonoscopy, but not willing to pay for these GLP-1 drugs, and it's costing $1,000 a month. These GLP drugs and the lifestyle changes are going to help with the fatty liver. That's one of the worsening diseases in US as well as India, causing liver failure. That's more reason why we need, medications do have side effects, but when they are doing a lot more good things, we have to look into it.
Just one thing on fatty liver. I always tell one thing to a lot of my patients, that your liver, your body is resting at night. Your liver is the one that's cleaning all the toxins. And I say, if you're going to give the liver two things before you go to bed, one is sugar, one's a little cholesterol. It's going to collect it instead of taking it out, which means your glucose is going to get converted to cholesterol and vice versa and go into your liver. So you want to give your liver some rest before you go to bed so it can do its job of cleaning and not collecting junk. Simple. It's a chemical factory is what I say.
Sleep hungry. Sleep hungry, correct?
I tell my patients, if it tastes good, spit it out. Is it common for type 2 diabetics to have their medicine changed every 3 to 4 years?
So there is something called evidence-based medicine. What we do today, we may not do tomorrow. And what we did yesterday, we are not doing today. That's the long and short of this question. So why do we change medications every 3 to 4 years? Or maybe even every 3 to 4 months sometimes? It all depends on patient condition. What is going on? Did they develop anything new that contraindicates or precludes us from using the medicine that they were on, and we have to make that change? Did they develop new kidney disease? Or now are they on dialysis where some of those medications may be contraindicated? So yes, we do change medications, but it's all dependent on what specifically is happening. And then, like I said, we have newer medications that are coming on the market with better profiles. Like right now, every medicine that comes into the market, especially for diabetes, has to show cardiovascular benefit as well. So if there is benefit, I think Sivani had alluded to SGLT2 inhibitor. These are other medication classes that have shown a great improvement in not only diabetes management, but heart health, kidney health, and many more effects. So yes, we do change, but there has to be a reason for the change.
I might add one more thing. Diabetes is a progressive medical condition. So it gets worse over a period of time. So it is inevitable that we may end up changing medications or add on new medications.
Probably we have pancreatic gland that produces insulin. When it's 50% damaged, that's when we get diagnosed with the diabetes. The rest of the 50% slowly gets damaged over the time. So you may need more and more medications to control the blood sugar. So that's why it keeps, you need to keep getting medicines changed according to your situation.
So in type 2 diabetes, the main problem initially is insulin resistant. I describe it as flogging a dying horse. We have, the pancreas is working overtime. It can't keep up with enough insulin. If you measure insulin levels in type 2 diabetes, they're already high. So it's like you're pushing and pushing something that's not able to work as well. That's where all the medicines that we've mentioned come into play. The Jardiances, the SGLT2s, the GLP-1s, etc. So sulfonylureas were the initial drugs we used, which used to make the pancreas push out more insulin. Those have almost gone now because it's so non-physiologic. All the newer drugs are so much more physiologic and work much better than the. Here's one for nutrition. What are your thoughts on alcohol and paneer?
Okay, paneer is a protein, of course. Yeah, we need to have that before alcoholic drinks. But then again, alcohol, there is moderation, right? There is like 2 drinks per day for males and 1 drink per day for females. So we do suggest that having that to decrease the absorption of alcohol, we need to have some type of carbohydrate and also the protein. That's my thought is the moderation, okay, for the alcohols, 2 drinks per day. Doesn't mean that you have not done Monday, Tuesday, Wednesday, and then Friday comes in, you will do 10 to 14 drinks. That is not acceptable. So it is 2 drinks per day, regardless of whether it is 1 time a week or 7 times a week. But then again, when we talk about Mediterranean diet patterns, alcohol, you get hard liquors and the red wine. So the Mediterranean diet focuses on the wine. So compared to red wine is the best choice compared to any other types of alcohol. And then combined with paneer, yes, it's good, but again, moderation is where I stop the alcohol.
So the interesting part is that GLP-1s do actually decrease the taste for alcohol for many people. And there are actually studies underway right now trying to see if these medications could actually be used for alcohol abstinence or alcohol rehab programs. So, and drug addiction, of course, yeah.
I will add one more. Again, addiction. There was a case report. A woman had shopaholism. And Ozempic cured the condition.
So, as far as alcohol is concerned, the growing trend in thinking is that any amount of alcohol is bad for you. The US recommendations are 2 drinks a day, I think for men, and 1 for women. Don't binge drinks. You're not supposed to drink it all at one go, your weekly worth, because that's more toxic to your liver than having 1 a day. So if you are going to drink, spread it out, but none is better than some.
I would say if you've all seen that Khosla Ka Ghosla movie, Hindi movie, and Anupam Kher says, hold the drink. That might be a better approach.
I don't know, that's how I started. I held it, and then I got thirsty and I started drinking it. So, don't even have it in your hand. Okay, another one for nutrition and therapy. reversal of type 2 diabetes with diet and exercise. Can it really reverse it, or is it brought into a manageable state without need for medicines?
I think that's an excellent question. Yes, with the lifestyle change, especially the calorie control and weight loss, and also with exercise, we can bring that A1C levels in a manageable, like pre-diabetes levels, or to the normal levels. But again, diabetes is not like a curable condition. We can only prevent the symptoms. So bringing down the hemoglobin A1C, and then managing the symptoms of micro and macro vascular diseases is the important. That's where the diabetes can cause the micro and macrovascular diseases. So controlling those diseases and progression of the symptom is important. And definitely, yes, we can reverse, but we are not going to take away the diabetes out of the system. It's there, but you are going to decrease the symptom.
Yeah, so I have, so many of my patients we have been able to reverse just with, lifestyle changes, nutrition, as well as exercise. And even having, higher A1C, they have come to pre-diabetic and normal levels as well. I think the main thing is that the continuation of that lifestyle for their life, that is the main thing. If they don't do it, it always comes back. So with nutrition and exercise, it has to continue. Yeah.
So diet, exercising 30 to 60 minutes a day, behavior modification is much better than a lot of medicines at preventing diabetes. Also, if you can reduce your weight by 15 to 20%, that can cause remission in about half the people who have diabetes. So it's a pretty good thing.
Yeah, I was going to say, use the word remission, actually. Reversal, once you have diabetes, you have diabetes. We have a definition for remission. We call it remission. If you can keep the hemoglobin A1C under 6.4% for 3 months without any prescription medications, you are in remission. That's a good thing. You can probably continue the remission for many, many years, actually. You still have diabetes, because remember, when you get diabetes, you already lost 50% of your pancreatic ability to produce insulin, actually. So we still don't have a good medicine to reverse that aspect. But with the good lifestyle change, you can stay in remission for many, many years. Even though, let's say you have 50% to begin with, right? You only had 50%. That 50%, with the good lifestyle change, you may be able to keep it for a long period of time. But naturally, you may lose 3 to 5% every year, actually. So, but that part you have a choice. With the good lifestyle change and continuing the lifestyle change, you can maintain that.
So I would also say that if you do achieve remission, don't say you're not diabetic anymore. You should still be treated as a diabetic with all the appropriate vaccinations, other preventative statins, and if you have cardiovascular problems, aspirin as well. So do not say you're cured of it, because you're not cured, you're just in remission, and you should still be treated as a diabetic. And anyone want to talk a little bit about bariatric options? Yes.
One point, you guys might be hearing about a lot of talks about reversing diabetes with the lifestyle medicine. As I mentioned earlier, by the time you get diabetes diagnosed, 50% of the pancreatic beta cells are not functioning. They are not going to come back. But you are going to stop or slow down the rest of the 50% unless there is a fatty liver. Just like that, there is fatty pancreatitis. They get fat deposition in the pancreas, which is not working. With the weight loss, it kind of starts acting again. But it does keep changing. So as Dr. Sangani mentioned, other doctors mentioned, once you are a diabetic, you are a diabetic rest of your life. But you are keeping it under control by lifestyle changes. And that's the point I wanted to make.
So is there a thing like pre-diabetic?
Yes.
Yeah. A1Cs of 5.7 to 6.4 is considered pre-diabetic or glucose intolerance.
So there are different stages of how blood glucose impairment happens. So initially some patients, like, if you look at research studies, they can actually become hypoglycemic in the initial stages. And then you can have impaired fasting glucose, where what we have defined as normal blood sugar levels after 8 to 10 hours of fasting are higher than that. But if you look at their A1Cs, they're normal. And if you look at their what we call post-meal glucose excursions, they're not super high, where you would kind of get diagnosed with diabetes. And eventually, over years, if no lifestyle changes are made, then it progresses to pre-diabetes, anything between A1Cs between 5.7 to 6.4. And then if you're over 6.5, then you are considered a diabetic. However, also keep in mind, A1Cs are not your whole and soul of what diabetes management is, because there are lots of factors that can affect the hemoglobin A1C and give false high or false low values. A lot of people with anemia will have a really normal A1C, but they actually have terrible blood sugar control. So that's why, when you have a diagnosis of diabetes, test your blood sugars as well. May not need every day, but a few times a week is a good idea to see where your blood glucose variations happen, and then you can address and target those accordingly.
We do have a question from our live audience. So first of all, they said they are really thankful. This has really been beneficial for them. The question is that if someone can comment if it is safe to participate in clinical trials, since these are still some newer medications.
So my answer will be a little nuanced. Yes, it could be safe. It all depends on what the study is and what are the requirements for the study. And based on that, if they qualify, if they meet the criteria of what the researcher is looking for, they certainly can participate, absolutely.
So, quick question about, somebody had asked about gadgets and their use. We've seen a lot of new glucose monitoring devices, which are like $50, you can throw them out. Is that helpful for the normal population?
Yes, it can be very helpful for people without diabetes. So these, we have two available on the market right now. One's called Stello and the other one is called Lingo. These are made by companies that actually make professional CGMs or continuous glucose monitors. The difference is that there are no alarms in the over-the-counter sensors, so they won't tell you that if you're going low or high, and you can actually adjust the blood glucose ranges if you have diabetes or if you do not have diabetes. So personally, I believe that they can help, for sure, because you can see what foods cause your blood sugar spikes, what does stress do to your blood sugar, what does exercise do to your blood sugar, how a disturbed sleep pattern could affect your blood sugar, and you can make those lifestyle changes. From that aspect, absolutely. Now, if you take it to the extremes, and then, because no device or anything is foolproof, right? So there is something called false low alarms. Like if you lay on the sensor on the same side that it is on your body, you can get a false low alarm. And that people are panicking, I have low blood sugar, and they're eating, so they are actually not using it to their benefit. So yes, it is a nuanced approach, but in general, I feel that it actually could be very helpful to improve your health.
I do also want to add, having low blood sugar is more dangerous than having high blood sugar. And so that's why those monitors are very important. When you, in the middle of the night, if you experience low blood sugars of less than 70, that's when we recommend patients to wake up and drink like 15 grams of sugar. May that be a glass of orange juice, some crackers, just to bring those blood sugars back up. So I think the main counseling point when patients are on various medications is they might be like, we need to make sure my sugars are low, but low in sense of between 80 to 130 is what we say is good. To keep it at less than that is very dangerous. So that's something patients and family caregivers should monitor as well.
One other thing, and as far as exercise and sugar levels, you tend to spike your sugars 1 to 2 hours after you eat. Taking a 20-minute walk starting 1 hour after you had started your meal helps bring down the peak a lot. So that is one thing I tell all my patients to do is once they've eaten, wait an hour and go for a walk. Something simple like just a gentle walk is enough to bring the sugar down. You don't have to do any major exercise, but a post-meal walk is very useful. And diet related. Our chapatis have a lot of wheat in them. Phytic acid binds to iron. It's another cause of iron deficiency. So you want to make sure that if you're, especially Asians, vegetarians, you want to be taking iron supplements. If you're on anything for acid reflux, make sure you take B12 as well because the medicines lower your B12 and maybe magnesium quite a bit. Hate to market any place, but a lot of these wholesale clubs sell their B12 very cheap, much cheaper than the supplement stores. So I often tell patients to go there, get their B12 from there, and then take that, 2 to 3 times a week at least.
So a large majority of South Asian population will have, as was alluded to previously, B12 and iron deficiency and vitamin D deficiency. I call it the holy trinity of South Asian diets, and that's a lot has to do with how we cook, prepare our meals, and many a times people don't want to take iron supplement because it is constipating. A large part of the oral iron supplements that are available in the market, except a few, can lead to constipation. What you could do is there is something called an iron fish. It's like a little iron fish that you can buy on Amazon. And while you're cooking food, put it in, take it out, add a little lemon. It helps with better absorption at the end. B12, absolutely fry those foods and B12 is all gone. Okay? So taking B12 supplement, especially if you're on metformin, is very, very important. Besides, in general, if you look at majority, I would assume almost 70% here are B12 deficient.
I have a question. What if you don't get 7 hours of sleep? I can only 3 hours. What do I do?
Sleep is very important. Okay, so when we talk about lifestyle, I usually start with sleep. People don't understand how important sleep is. It's better than any prescription medication. So the body, a lot of repair mechanisms happen in the body, or stress hormones come down. If you don't get enough sleep, the cortisol will be very high, which is a stress hormone. So if you look at humanity, our human body, all our hormones follow a light-dark cycle. It's entirely related to sunlight. So our biological clock, which has not changed in 40,000 years. And we are living in a society where there is electricity and light everywhere on all the gadgets. Only 25% of people in this country get adequate sleep. So you are in the majority, sorry. So including children, adults, nobody's getting enough sleep. And lack of sleep is also one reason for obesity, unfortunately. So I don't know how to tell you to get enough sleep, but one is habit. So, I'm not a specialist, but I use common sense when I counsel my patients. It's an acquired habit. We can retrain the brain, but it takes several weeks and months perhaps. So having a bedtime, not having any gadgets in the bedroom, no television in the bedroom. If anybody has it, please remove it. And not having your cell phone, laptops, anything, turning everything off at a reasonable time, having a peaceful gap between your activities and going to bed helps. The old way of reading a book and falling asleep is probably a good idea, but do not watch any television. Do not leave that TV screen on when you go to bed. Even the light trickling through your windows disrupt your sleep actually. There's enough scientific evidence to support that. Sleep is so much important. So when we talk about lifestyle, usually we limit with the diet, exercise. No, sleep is very, very, very important. 6 to 7 hours, 6 is bare minimum, 7 to 8 is preferred actually. But if you're not getting that sleep, you're always on a deficit budget actually. That is not good. In the long run, it has a lot of health outcomes. People who work night shift, we have enough evidence to suggest that they have a lot of bad health outcome actually. So building that habit of adding, I have a joke in my office, like, some patients, they go to bed at 2 o'clock in the morning. I say, please go to bed the same day. You cannot go to bed at 2 o'clock, that's next day actually. So you have to have a bedtime, turn everything off, and then working with your brain, you can improve it. But I don't know if there's a complete solution for insomnia for the 75% of people suffering in this country. Do you?
As I treat elderly patients, this is the frequent complaint I hear. First of all, we call it as sleep hygiene, as Dr. Abraham mentioned. Going to bed same time every day and not napping in the daytime. If you nap in the daytime, then your sleep drive is already satisfied, so you don't fall asleep at nighttime. And when you wake up in the morning, you gotta get some good light. So your brain knows it's daytime, I should not fall asleep, I should stay awake. Then the whole day long and not sleeping in the afternoon, waiting for your bedtime, having a good meal, good comfortable temperature in the room is a few things that you can change in your environment like that. Nice bed sheets, quiet ones, keeping the room quiet. And the last resort wise, melatonin is a hormone our brain secretes. It goes down with the age. So melatonin is something that you can take, you can try. You can buy it in the over-the-counter, try it. But not just melatonin won't work. You have to do other things. Sleep hygiene, very important. These things seems to work with our elderly patients.
I think we're coming to the close of our time. Can I ask one last thing? The concept of lean diabetes, would any of you like to comment on that? It's more common in South Asians.
Sorry.
There was a study done in India. It's actually Indian research scientists came up with this. There are 4 types of diabetes in India. You guys might have heard during the English ruled India, there was a famine. People did not get, I think Bengal area, Bangladesh or Bengal area, there was a famine and people did not eat that much and they developed, their body changed, the genes changed so much that in certain families, even though they are not heavy set, they develop insulin resistance very young age. They look very thin, they look like malnourished, but because the pancreas did not develop much and it doesn't secrete enough insulin. That's why insulin we need it to build the muscle, to get the muscles bigger and all those things. If there is not enough insulin, they don't grow to the normal size. That's where that lean diabetes, I can share that article later on. That's what happens. They develop at very young age. There is a fat diabetes, lean diabetes, there is a mixed variety. All these things are in India. It's because of that long ago what happened to our population with the famine and all.
And more than just the famine, the way I say it is South Asian population, we were meant for hard work back few generations ago. Our body is used to hard work, less nutrition. So the way the genes are made, the body responds to this, the body is in a survival mode. You can eat less, but you can still function. Now you come to a different country, generations go by, you eat differently, your body is in a conservation mode. So now one extra calories that may not impact other races will impact the South Asian community. And I say it takes 5 to 6 generations before the body understands saying, okay, this is a new lifestyle. I may not need to be in a survival or conservation mode, but that's going to be few generations down the road. For our generation, it is the amount of calories for a hard-working population.
Yeah, and as far as all the different diets go, I don't know if you'd agree with me, everyone responds differently to a different diet. What works for one may not work for the other. But when you come down to it, it's the amount of calories you're taking in. That's the net root of the problem. The more you eat, the more you're going to get fatter, increase your adipose tissue, and have a higher risk of diabetes. I think 80% of diabetes can be attributed to obesity. So it's one of the major causes.
Okay, so I think we all want to thank the panelists on behalf of IAKC for this wonderful lecture. They spent almost a lot of time coordinating this. So on behalf of IAKC, and also thank you to all the members of IAKC who helped organize and put this together. Our next announcement was that we have a health fair like this on 27th of June. So take advantage of that health fair. We have booths, again, physicians will be there, people from the community will be participating. So make sure you enroll for that, get some of these checkups done over there, which will be helpful for you. So again, thank you everybody, and thanks to the panel. Yeah, and thanks to Dr. Padmaja too, without which this would have not been possible. Thank you.